with laparoscopic surgery, you transfer the pain from the patient to the surgeon or to the endoscopist. And I think that holds true in many ways. And this, I truly believe, this won't be the focus of today's talk, but I do talk about ergonomics, and it's a topic very near and dear to my heart. But lack of attention to ergonomics can be an occupational hazard. And many of us know colleagues and friends that have had neck, back surgery, or even been debilitated for short or long periods of time without attention to this. We actually do have an ergonomics lab in which we study ergonomics. We both use objective measures such as EMG electrodes, and also subjective validated scores such as the NASA TLX to measure this. We've published on a couple different venues on both open and laparoscopic, robotic and endoscopic modalities. I'm happy to talk at length afterwards if anybody's interested in that piece. We also look at provider factors, such as how your level of training impacts your ergonomics, your specialty area, even your hand size, and also patient factors as well. And this isn't limited to laparoscopy. All the endoscopists in the room know this very well also. And this is just limited to our technology. The endoscope, arguably is a technology that largely has been unchanged for the last 40 years as far as its design. Yes, the optics have gotten better and high resolution and so forth, but it was originally designed as a diagnostic tool with itself has limited degrees of freedom. Your eyes and your hands work together. So if you're gonna, move left, your hands move left and vice versa. And then again, the dials present a lot of ergonomic challenges. It's basically a one-size-fits-all tool, and we know that we are not all one size. In fact, this is a study that's be coming out here shortly in where we looked at ergonomics of endoscopists and looked at a number of factors, but one of the key things that we discovered, which may not be a surprise, but I think helped to validate it, is the hand size of the operator significantly impacts one's ergonomics, with the smallest hand size having the most ergonomic strain, and then medium, and then large. Of note, all of the endoscopists in the small hand size were females. All of the males were of the medium and large size. And so, again, this just goes to, I think, for our industry partners, why it's so important to pay attention to these things and recognize that, again, this is not a one-size-fits-all field. The field of surgical ergonomics took off dramatically around 1990. Anybody want to hazard a guess as to why in surgery this field took off around 1990? Yeah, I think I heard a couple. So the advent of laparoscopy. That's again what prompted a lot of this study. In addition to other things such as the recognition of it as a field itself, and concomitant with that was the rise of robotics, recognizing that the limitations of conventional laparoscopy and how we could overcome them. There have been many historical robots that came out in the early field. One for soft tissue surgery has been the predominant one. We had it on display here on Thursday, which is the Da Vinci robot, now in kind of its fourth iteration or generation. And it was designed to overcome a lot of these challenges of laparoscopy that I spoke about. It's good at doing pretty much all of these except for one. And again, I'll ask the surgeons to hold their response here for the gastroenterologist. Which one of these does the robot not help with? Haptics, yeah, that's correct. They're working on that, but we're not there yet. And concomitantly, robotics has grown fairly dramatically over the last 20 years as a result of refinements in the technique and greater data showing its value for both patients and for surgeons. We've also looked at ergonomics of laparoscopy versus robotics. A number of us who use the robot subjectively feel that it provides us with ergonomic advantages, but can we quantify that? This is a very early study we did in the simulation center with basic laparoscopic tasks of increasing complexity. In the blue bars there, you see the ergonomic strain as measured by EMG increases when you're doing straight stick laparoscopy as the task complexity increases. When you're using the robot, however, it's low and it stays low regardless of the task complexity. and this is just true for a 5-minute basic skill. We also looked at this in the operating room as well. The dark bars are the traditional laparoscopic surgery, the white bars are robotics. You can see pretty much across the board improvements in ergonomics, but not universally. The trapezius muscles actually have higher activation. For those of you that use robotics, I don't know if you've ever noticed this, but sometimes you can really feel it in your shoulders. So again, we're working with industry partners to try to help even improve that domain as well. Not just for the surgeon, but we do feel like the robot does now have some advantages for the patient. It has been shown in other areas. In foregut surgery, it's been used more increasingly recently, and we're now able to collect some of the data. Dr. Houghton kindly alluded to some of the work we've been doing. In our short-term outcomes data, we're really pleased to see some favorable outcomes in operative times, length of stay, blood loss, intraoperative injury, and so forth. We also published in Journal of American College of Surgeons last year our 10-year longitudinal data set, also with robotic procedures. The main finding, there were a number, but the main finding, and this came up in the last couple of days, we all know that one of the most difficult and persistent challenges with hiatal hernia repairs is the recurrence rate, as high as 59% in the published literature at 5 years. We were really pleased to see that we're hopefully starting to make a dent in this. And again, we can talk about this a little bit and maybe some of the factors. I think we all recognize the importance of a high mediastinal dissection. We heard the importance of additional kind of stitches, the hill stitch, as mentioned by Dr. I yesterday in his talk. And this has exploded. There have been 77 different robotic surgical companies out on the market today. Now, not all of these are in the abdomen, but you can see the ones on the right-hand side there that are focused on soft tissue robotic surgery. So it's an exciting time. These are just a sampling of the FDA-approved platforms. We're not going to go into all of these today, but I did want to focus on this unique area where the AFS really focuses, and that is that significant overlap between our gastroenterology and surgical procedural domains with flexible robotic systems. I would point you to an excellent review article by Barbara Siegler and Lee Swanstrom published last year, which goes over a number of the systems that were done recently. And again, I'll just highlight a couple of these. Won't be able to go through all of them. But this is a Flex robot made by Med Robotics. It's a stable platform that's with a camera, and then you have these kind of handheld instruments that you feed through the two working channels there. It's a little bit larger. It's about 25 millimeter outer diameter and about 30 centimeters in length. So it's really not something we can use to reach the stomach, but it is right now used for kind of proximal transoral work by the ENT colleagues, as well as for colorectal work as well. This is a product called Ion, also made by Intuitive. This is for bronchoscopy, but I pointed out because of its some of its intriguing features. It's a 3.5 millimeter. It's got kind of an interesting, cursor, a rolling wheel to operate it. It's stable. It's got this kind of registration, thing to see where you are in space. And you can quickly imagine how this could be translated into, this is a 3.5 millimeter object. If you could bring that up to what we use in the endoscopy suite, 9.5 millimeters, how you could really do facilitate some work with that. And there are a host of other robots that are in development that aren't commercially available yet. This one is at NTU, what's called the Master Robot, with these kind of sophisticated end effector tools that allow you to do some grasping and sophisticated work. This one is called the Carpi robot, which is segments of the endoscope that are all robotically controlled. And so you can kind of snake through, avoid some of the alpha looping and so forth, especially for lower endoscopy, and also is controlled with joysticks, hopefully more ergonomic than we're used to. This product was also here with one of our exhibitors today by ANX Robotica, the Navicam. Now we're talking about capsule robots. This is a capsule that is magnetically controlled externally from the patient, and it can be used to kind of do these 360 scoping or survey of the lumen of the stomach. Again, it's a capsule swallowed by the patient. And there's capsules that are self-controlled, don't need an external source. This is a motor-based capsule that's kind of like an inchworm and kind of compresses back and forth to try to get motility through the GI tract. This one's a little wild. For those of you that have seen The Matrix, this kind of reminds me of the first Matrix movie with Neo in the back of that van that car that picked him up. This is kind of got these little kind of graspers that can move back and forth and propel itself through the GI tract. It's shown here in a fluoro in an animal model to show how it can kind of traverse the tract. So, future directions. What we focused on really to date is kind of the motor or the mechanical piece of these systems. But I think where we're going to really see the innovation is in these latter areas, both in vision and what we call analytics. And robots really being more referred to as computer-assisted devices, because that's really what the heart of this is. We're seeing some really amazing opportunities with fluorescence imaging that you've seen in some of the other talks here today. In vivo microscopy has been known in flexible endoscopy, but also for some new robotic systems that are coming out. Image guidance. We have phenomenal preoperative imaging available to us today with CAT scans with sub-millimeter resolution. But then we go to the operating room, and we have the same thing that we've had for the last 400 years, which is just our eyes. How can we bring that kind of high-resolution imagery back into the operating room and help us guide us? So this kind of registering the images to tissues we're working with intra-abdominally, especially for soft tissue, help us look for no-fly surgical zones. We're going to hear a little bit much more about AI in a subsequent talk here shortly, but the use of augmented reality, this is using intra-abdominal ultrasound and overlaying the image of a kidney, and you'll see the renal pelvis and collecting system shown there. That circle is meant to simulate a lesion and to help us kind of identify the resection areas to see almost beyond what we can see with our eyes, kind of an X-ray vision. And then what's sometimes referred to as cybernetic surgery, robotic surgery, using simulations of the patient to help us plan our operative approach, to use soft tissue deformation, registering it to the preoperative images, again, to kind of see within the organ using the images. And finally, just a plug on the future of education in robotic systems. And this is a fun video that I like to show. It's, this surgeon is at an important family event. I think it's supposed to be his daughter's wedding. He gets paged because he's needed in the operating room, and he does all this cool stuff. Very Minority Report looking stuff. Anyway, you get the idea. We're not too far off from that. Here's a surgeon who was in Florida. I was in my office in St. Louis. This kind of was particularly accelerated by the pandemic and allowed us a bit of a silver lining of all of this to be able to look at how we could work with other surgeons remotely. Here's myself doing a remote case observation with some surgeons who was trying to see if robotic foregut was right for him. And he was able to see what I could see in the robot, hear what I could hear, and we had a discussion. He was in Wisconsin, I was in St. Louis. And finally, just a plug for our AFS Foregut Society Robotic Mentorship Program. This is a wonderful opportunity, again, an example of our industry partnership with Intuitive Surgical, who's sponsoring this. Dr. Houghton, Damani, Bell, and myself are the first round mentors. And for those of you interested in that program, please reach out to one of us. Thank you again for the opportunity to present.
Mike, thanks very much. That was fantastic. You're welcome to stay on the stage or run off if you'd like, whichever you prefer. It is amazing having been on the team that did the first transvaginal cholecystectomy back in the mid-2000s to see how these technologies that we kind of dreamed about are really coming to fruition now. So that was a terrific survey. Thank you. I'm going to introduce our next speaker, who unfortunately was not able to join us in person and will be presenting through video, and that's Dr. Stavros Stavropoulos. I'll just tell you a couple of quick facts about Stavros. Many of you know him already. I will tell you, he has no fear of pushing the envelope and moving forward and advancing the craft of medicine and endoscopic surgery. I think we unintentionally together in the ICU at Columbia did one of the first pancreatic necrosectomies because he said, well, what's in there? Should we go look? I didn't know I was a first-year fellow, so we did it, and it's amazing to see where that technique has progressed. Stavros took that spirit of inquiry with him when he moved to Winthrop, now NYU Long Island, back in 2007, become the head of advanced endoscopy there, and as we all know, has become a leading expert across the globe in POEM, and now with endoscopic submucosal resections and STIR and EFTR and all of the great acronyms that we've developed for sampling beneath the surface and doing even full thickness resections. So Stavros is going to talk to us and give us his perspective on the third space and how these techniques have moved in. So let's roll that video here and have him join us for his presentation.
I would like to thank the AFS for inviting me to lecture, especially for a visionary subject as the future of third space. Generally, I'm a little ambivalent for this kind of crystal ball lectures. It's tough to make predictions, especially about the future, as Yogi Berra said, and I don't have enough white hair and the wisdom to predict the future, but I'll do my best. POEM has clearly become the king of third space. It's the first successful nodes procedure, now first-line therapy for achalasia with its own CPT code. I encourage all of you to catch our new publication from a few months ago, largest Western series of POEM, 610 over 10 years, with only 2.3% of patients missing follow-up, courtesy of my very diligent co-workers. You can see now at 7 to 10 years, 91% success in our series, very good estimates and very high safety. So POEM is basically the cornerstone of this new third space revolution, and I see two trends developing in the near future. There's the new nodes procedure spawned by POEM, all the myotomies, POEM, G-POEM, Z-POEM, PREM, D-POEM, and then there are the tunnel procedures to resect tumors, either STIR for subepithelial tumors or submucosal and ESD. Also, POEM massively accelerated ESD adoption in the US. But there's also another trend of reinvigorating traditional nodes. We have a Korean study, for example, already in 2013 doing peritoneoscopy with biopsies under conscious sedation. We have EFTR, the full thickness resection, making holes, removing cysts and suturing them. So, in sum, these are the two trends I see in the future. Increasingly creative tunnel-assisted interventions, what we call the new POEM, the new nodes, short-range interventions near the GI wall, and then longer-range interventions well beyond the GI wall, reviving traditional nodes concepts. The third space revolution, particularly POEM ESD, is creating basically a generation of physicians that are very skilled in the essentials of surgery: tissue dissection, vessel coagulation, confident entry to body cavities, and management of pneumoperitoneum and pneumothorax, and secure closure of full thickness defects. All these are essentials of surgery, which we did not have on our first foray in traditional POEM when people doing ERCP tried to get a needle knife and remove the gallbladder, and that didn't work very well. Now, in this very insightful article by Pastrica back in 2012, different possible applications of the tunnel third space endoscopy. Some of them already realized: tunnel-assisted ESD, check; full thickness muscle biopsy, for example, or the stomach, to detect cells of Cajal or ganglia, check; submucosal tunnel endoscopic resection for subepithelial tumors, check. And then these futuristic applications I will discuss briefly: drug delivery, maybe in the future, harvesting and implanting stem cells in the future, placement of stimulating or monitoring devices, and reshaping anatomy through myotomy. I'll discuss this. So first, this is a pet project of Chris Gostout, an endoscopic link system for reflux. Basically, the POEM tunnel is taken one step further. A POEM tunnel is performed and a small muscle cut is done. A new tunnel is made in the adventitial space where magnets are inserted. This is what it looks on necropsy: little magnet in the adventitia of the esophagus. And you can see the endoscopy looks like a lynx. The magnets are posed and the scope goes through, and the magnets lose contact. Pretty much an endoscopic lynx kind of system for reflux. Drug delivery, again, Chris Gostout is telling me that they're looking at submucosal tunnel insertion of constructs that release slowly pharmaceuticals for EOE therapy or biotech prevention. Then studies are looking at implantation of pacemakers. In this study, which used POEM and nodes in 5 pigs, they did a tunnel dissection in the fashion of POEM from the esophagus to the lesser curvature of the proximal gastric body. Then they exited the muscle into the abdominal cavity, grabbed some leads from a subcutaneously placed pacemaker, brought the leads back into the tunnel, implanted them in esophageal muscle, and closed the muscle. Close the tunnel, and then you can see on manometry measurements for 6 hours entrainment of the muscle from these electrodes, proving the concept that you can place a pacemaker that may correct peristalsis in diseases like achalasia. Stem cells, very early, but this is maybe patient number 1 in the world. He has his own blog. He calls it a moonshot, my moonshot to cure achalasia. He cooperated with J. Pastrica and Hopkins. They cultured skeletal muscle cells and implanted 225 million cells in 10 different targeted areas of the esophagus. Unfortunately, didn't work. Now they're preparing to try 500 million cells, and as J. Pastrica told him per his blog, one way or another, we did make history. But obviously very early in its development. Now you can have tunnel-assisted extraluminal foreign body extraction, increasing number of reports for removing foreign bodies in very difficult locations. We submitted this in DDW 2019, needle from the duodenum into the pancreas. In this patient, you can see it fluoroscopically, but nothing is visible endoscopically in the duodenum or pylorus. It's through the mucosa and submucosa and possibly even the muscle. So we mark under fluoroscopy where to dig, and then we make a nice little anterior G-POEM tunnel and a little bit of a myotomy to expose what we finally see as the edge of the needle in the muscle, and we grab it with a forceps and pull it out into the scope and bring it out from the body. And then we close the tunnel with suturing as we do our G-POEMs. Now, a similar application from my advanced fellow Krishna Guram got the best of the best award in DDW this year. Removed a bullet using a tunnel from the rectum, as you can see here. So this is one more creative application of the tunnel. Oh, sorry. So basically now we'll discuss as the last application reshaping anatomy, post-bariatric anatomy. 56-year-old woman, gastric sleeve in 2001, converted to Uruguay bypass 2020, unable to tolerate, however, even liquids postoperatively, TPN dependent for the elapsed 15 months in surgery, balloon dilation and stent at the GJ anastomosis ineffective, bacteremia from TPN that seeded her knee requiring drainage, hospitalized at outside hospital for 3 months, prior to referral to our hospital, and upper GI showing stasis in this diverticulum immediately after the EGJ. This is what it looked like. Sorry about this. You can see here basically tight lumen and the septum and a very big diverticulum on the left. Looks very much like a Zenker's. So we basically used our Z-POEM technique, which involves making a mucosal incision at the top of the septum and then doing a myotomy, and eventually we reached the staple line of the previous sleeve that was revised, and we removed some of this. You can see we switched to the hook knife and remove staples down the sleeve staple line there, and then we get this nice result. We suture the tunnel closed, very safe, and then you can see a very narrow diverticulum on the left now, very shallow, and a much more open lumen on the right. The results for the patient were spectacular: complete resolution of vomiting, able to tolerate soft mechanical diet immediately after the procedure, doing well on solid diet now a year after the procedure with no complaints. This video got this year's DDW the best for the bariatric section. Also from this year's DDW, now we move to the traditional notes being invigorated kind of future trend. You can see Pingong Jaws, amazing group in Shanghai. In order to remove extraluminal tumors such as this, they make a tunnel and exit into the abdominal cavity, and then they drew true, pure notes, resecting the tumor from the peritoneal side the way you would do it laparoscopically. It provides very good visualization of any dangerous vessels, and it makes it much more easier to close the hole than straight EFTR. So very intriguing technique and true nodes. Now, an iconic nodes procedure, endoscopic appendectomy, The appendectomy by Reddy in 2004 or 5 was what kick-launched the notes era back in 2005. So now we are coming back full circle, endoscopic appendectomy by this group in Shanghai, Meindong Zhu's group. You can see a straight EFTR approach at the base of the appendix. They cut the appendix from the base and then extend the mesenteric dissection alongside the appendix. Difficult because it has significant risk of leak because of the EFTR portion and difficult approach of the appendix along the axis of it. Now, improvement on that by Ping-Hong Zhou again, personal communication. This may come out in a publication in JGH where they submitted tunnel-assisted nodes appendectomy. Make a tunnel in the cecum exit and then have a lateral view of the appendix similar to what a laparoscopic surgeon would have. Put an endoloop, use a snare, cut it after first dissecting the mesentery. So very nice approach. We are waiting to see the data on that. And of course, another iconic nodes procedure, endoscopic cholecystectomy, now done in China by Ping-Hong Zhou in quite a few numbers. So this is these beautiful pictures, exit the stomach, do a dissection of the appendix the way the gallbladder, the way you would do ESD, from the fundus towards the triangle of Callot, coagulate the cystic artery, ligate and cut the cystic duct, and pull the gallbladder through the gastric defect and then out the mouth and close the gastric defect. This is their publication in endoscopy 2021, 8 cases. He did a live one in our live course in August, Long Island Live 2021. You can see here, for example, interestingly, the appendix being removed from the mouth with the endoscope, pure nodes, no assistance laparoscopically. He has done over 50 now, he said, at our course, up from 8 in endoscopy, with no conversion for emergency, only a few conversions for severe fibrosis that required laparoscopic resection. So very interesting stuff. Now, obviously, the anterior fundoplication invented by Nui, the POEM plus F or POEF. POEF done first in August of 2017. He reported it and showed it in our Long Island Live course in his lecture, March 2018. You can find it at our course website. Basically, going through the myotomy tunnel and then going out the muscle, cutting the peritoneal membrane, entering the peritoneal space between the liver and the anterior fundus, grabbing the fundus, clipping an endoloop on the fundus, then clipping the other end of the endoloop in the myotomy. And then as you close the endoloop with a retroflex scope in the stomach, you can see as the endoloop closes, it all bunches up in what looks like a door fundoplication for all intents and purposes. The durability is not clear yet. There are 2 studies from India, very interesting data, but the data are accumulating rapidly on this technique. Traditional nodes, proofs of principle, resection of a cancer with lymphadenectomy. This is from Ping-Hong Liu's group in Zhengzhou. T2 cancer in an inoperable patient. First, they inject carbon nanoparticles 2 days before the resection, then they resected the tumor and the sentinel node shown here. Very interesting technique, maybe in our future. So in conclusion, POEM, the first successful nodes procedure, has spawned a number of tunnel-based short-range new nodes interventions with creative and diverse applications, but perhaps more importantly, the third space revolution incited by POEM is producing a critical mass of endosurgeons, the foremost of whom are now returning back to traditional nodes procedures such as appendectomy and cholecystectomy with great success. Hopefully, the explosive endosurgical device development stimulated by the third space revolution will continue and expand again to encompass traditional nodes as a viable concept now in the hands of this new breed of surgery-capable advanced endoscopists. Thank you.
So I'm going to ask Dr. Sammarasina, who's our next speaker, to head to the back to get mic'd up. And I hopefully see him behind us. I just will say that I think we need to all get a cheat sheet with all the new acronyms that Dr. Stavropoulos and others have put in their talks, and we'll see if we can make that a party favor for AFS 2022. Let me now introduce our last speaker of this panel before we get into discussion. That's Dr. Jason Sammarasina from UC Irvine. He is an associate professor of medicine there and the director of advanced endoscopic imaging, and has really played a leading role in thinking in the last few years about the incorporation of neural networks and artificial intelligence and using those kinds of tools to improve the care that we provide to our patients. So very excited, Jason, to hear what you have to say. Please go ahead and welcome.
Thank you, Mike. So this is a kind of a passion project for me, artificial intelligence and Barrett's esophagus, and it's one of those things that I think we've sort of come a long way with endoscopic imaging, but we're still not quite there yet in terms of moving the needle in terms of dysplasia detection. And so we found that surveillance for Barrett's esophagus, and we've heard this time and time again now, the Seattle protocol just isn't working. We know that non-adherence is leading to some of that decrease in dysplasia detection, but even in the best of scenarios, it's really of modest benefit. So the ASGE set forth the PIVI criteria for neoplasia detection. And what this states is that if an optical diagnostic technology can reach these particular performance thresholds, we may be able to do away with Seattle protocol. And that was a per patient sensitivity of 90% of finding neoplasia, a negative predictive value of 98%, and a specificity of 80% for detecting early esophageal neoplasia. And we've seen a lot of technology and a lot of techniques trying to achieve those goals. Chromoendoscopy with dye, acetic acid spray, virtual chromoendoscopy with narrowband imaging, magnification endoscopy, endocytoscopy. We've heard Vani talk about confocal laser endomicroscopy and optical coherence tomography. But if you look at these technologies, none of them have really made the mark. Acetic acid chromoendoscopy and NBI have, but it seems to be only in expert centers with expert endoscopists. And so what makes somebody an expert with imaging? Well, a lot of it comes down to pattern recognition. And you don't have to be an expert to know that the pattern of the mucosa on the left side of this esophagus is different than the right side. But you probably do need to be more of an expert to detect that these two lesions are actually neoplasia and was in fact intramucosal adenocarcinoma. You probably need to be a bit more of an expert to not miss this lesion. And this is also an intramucosal adenocarcinoma that required an ESD. And this patient was referred to me for something completely different. It was actually for an EUS, and we did an EGD beforehand and found this lesion that was missed on the endoscopy a few months before. And I think a lot of us who are referred patients for Barrett's endotherapy have seen this scenario time and time again where an endoscopist with the same scope is looking at the esophagus just a few weeks or few months beforehand, and they're not seeing the same things that we're seeing. And I think when we train endoscopists in dysplasia detection, we think of things in sort of two modes. We have the sort of red flag detector mode where we're evaluating for suspicious lesions. We're telling people to look for anything that's raised, depressed, ulcerated, bleeding, discolored. And then when you see something, get a closer look at it, interrogate it, and if it looks dysplastic, you may be able to biopsy it or resect it depending on your skill set. But honestly, we've been training people to try and do this for a long time, and it hasn't really worked. And I think training this skill is challenging. And maybe it's time to train something else, and maybe a computer can help us with this. So there's been an enormous growth in research with artificial intelligence. This is our group showing that we can use a convolutional neural network system to identify colon polyps. And really, a lot of the work in Barrett's is an extension of the work that's been done already with colonoscopy. And one of the big projects we're undertaking right now in the colon is polyp characterization. And so polyp characterization and detecting neoplasia in Barrett's is very, very similar. It's, again, pattern recognition. So that's what we set out to do. And this is one of the first papers that we published on this. And I want to take you a little bit through the methods of this study to kind of understand how these AI studies are being put together. So the aim of this study was to assess if a convolutional neural artificial intelligence network can aid in the recognition of early esophageal neoplasia in Barrett's. So the the first step of the algorithm was a binary classification of if there was dysplasia or no dysplasia on the image. And the second step was seeing if the algorithm could detect where the neoplasia was localized. And so we took over 900 images in 70 patients of histology-proven early esophageal neoplasia using the Olympus system. The areas of neoplasia were masked using image annotation software by 2 endoscopists, and then we had 900 control images that were collected of histology-proven or confocal laser endomicroscopy-proven Barrett's without dysplasia. This is a quick look at the annotation software that we're using. And so the neural network is built on TensorFlow and pre-trained on ImageNet and a colonoscopy quality database over 800,000 images of endoscopic images from the colon. So then for the localization part, we had to define something called intersection over union, which is a threshold to see if this was going to be a true positive or a false positive. And this is in AI sort of science what is commonly used. So this is intersection, this is union. And clinically speaking, we weren't sure kind of where the threshold should be, and we decided that a threshold of 0.3 would be adequate for clinical use for Barrett's esophagus neoplasia detection. You can't really use sensitivity and specificity in these types of studies, and you have to use something called mean average precision. And this was an example of, say, detection. So in the red box, you can see what we annotated, and in the green box, this was the prediction by the algorithm. So how did the algorithm do with this image analysis? So a total of 458 images that were completely unique to the training set were used for validation, and the sensitivity and specificity and accuracy of the binary assessment, whether there was dysplasia or not, was very, very good. And when we looked at white light, MBI, standard focus, near focus, it was all very similar. In terms of localization, the mean average precision with an IOU of 0.3 was actually very high. You'll have to take my word for it. That was a good score. And so this was very encouraging. But one of the strengths of this algorithm really came from how quickly it can make predictions. So the binary classifier was able to run at about 72 frames per second, and the localization algorithm was able to run faster than 45 frames per second. And I'll get into why that's important in a bit. So this was encouraging. Based on esophageal images, we were able to localize esophageal neoplasia with high accuracy. And other groups, such as Dr. Bergman's group in the Netherlands, have done similar work. You can see that their algorithm is able to provide somewhat of a heat map as well as a target for where you should take your biopsy. And what they did here was a similar sort of training that we did in our study, and they actually compared what the algorithm predicted as the place of neoplasia to what endoscopists thought was the place of neoplasia. And in fact, the CAD system actually performed better than the endoscopist. So he's since taken things a step further, and he's done a pilot study in real time. So in this case, they took 10 patients with non-dysplastic Barrett's and 10 patients with confirmed Barrett's neoplasia. And during the endoscopy, they were asked to take 3 white light endoscopic images obtained every 2 centimeters at the 2 centimeter levels of the Barrett segment. They were analyzed by the CAD system, and then feedback was given to the endoscopist. And it took maybe a couple of seconds for that system to generate a prediction. And if 2 out of the 3 predictions by the system showed it was neoplasia, then a biopsy was performed. And so the per level analysis of the CAD system was very good, accuracy of 90%, sensitivity 91%, specificity of 89%. And so this is, again, promising results. I think one of the downsides of this system might be that endoscopists may not be willing to take a picture, wait for a prediction, take another picture, wait for another prediction, take another picture, wait for prediction. I think we all agree that we're very busy, and the hassle factor might just be a little bit too much. So I think what would be ideal in this space is a continuous real-time AI-assisted Barrett surveillance procedure or system. And so this is an early prototype run on a video. And what we'll see here is because the algorithm can predict so quickly, it's faster than the actual frame rate of the video. And because of that, we're seeing sort of a real-time box that is appearing. And I think this may be even more useful. And so here, when I show this video without the AI overlay, sometimes it's a little difficult for people to appreciate that this entire area that's being highlighted is actually high-grade dysplasia. And again, this is not a skill set that we are able to train fellows on very easily, because over a 3-year fellowship, you're not really going to see a ton of these cases. You're not going to be able to make the correlation with imaging and pathology like you can with a system like this in place. So here you can see that the algorithm is calling this area dysplastic, and then the area above it looks okay because there's really no box. The area to the left here looks okay, but it's sort of kind of drawing your attention to that area to the right. So with this result, we thought it would be a good idea to do a multi-center external validation study, and we worked with Vani Kanda and Arvind Trindad. And they sent me some videos to see how the algorithm would perform on just their own videos, completely had to be independent of the training set. And so we presented this at DDW this year. We had 40 video clips from 40 unique patients, white light MBI. The lengths ranged from 1 minute to 6 minutes. And 20 patients had at least one dysplastic lesion. 20 patients had non-dysplastic Barrett's. The videos were reviewed and identified in timestamp by 2 expert endoscopists, and we scored on a scale of subtlety of the lesions from S1 to S5. So in terms of the dysplastic videos, the algorithm actually detected 19 out of the 20 lesions with a 95% per lesion sensitivity. The only lesion the algorithm did not detect was an S1 lesion. For the non-dysplastic videos, we looked at all the true negative frames and the false positive frames, meaning that the algorithm drew a box on something that wasn't actually there. But we only called it a true clinical prediction if the box stayed on for more than 3 seconds. So in terms of false positive clinical predictions, it was actually 0. And the per patient negative predictive value in this small study was 100%. So again, encouraging results for hopefully a real-time AI algorithm. You know, I think the strength of the system is that it's true real-time analysis that's continuous and doesn't require freezing the endoscopy to generate predictions. And the algorithm may be ready for prospective live real-time testing. So in summary, you know, Barrett's dysplasia detection during endoscopy is still a skill set that's not easy to learn or teach. A real-time AI algorithm can potentially aid endoscopists detect neoplasia earlier so that appropriate preventative treatment can be carried out. And if the algorithm is able to exceed PIVI thresholds, the number of random biopsies in the esophagus during surveillance endoscopy could be significantly reduced. And really, the use of AI in Barrett's esophagus is not limited to dysplasia detection. There's already papers looking at quantitative measurement of Barrett's esophagus with the PROG classification, but I think AI could really be used to help coach endoscopists through sort of the high-quality exam that Dr. Kamanduri was talking about and Vani talks about, and also serve as a training tool for fellows and endoscopists, including surgeons as well. With that, thank you very much.
Jason, thanks so much.
Yeah, just a comment. It's really interesting how I think this session has really illustrated how there is a convergence of our fields, endoscopy and surgery. We saw Dr. Stavropoulos doing some really innovative things with the endoscope, and then if we can combine that with some of the robotic technology and have retraction and coagulation and things, we're unstoppable. So it's pretty cool. Any questions?
I'll invite the floor up. Anybody interested in making a comment or giving a question? And I think You know, we heard the report earlier from the Education Committee where there was the discussion of getting on the Fellowship Council and helping to shape the training for surgeons who want to specialize in foregut. And as I watched Stavros's talk, and I was, thinking about the other talks in this session, you could see where there's going to be a convergence where there isn't necessarily going to be a GI only or a surgery only pathway. There's certainly a hybrid pathway on its way before too long.
Tunisia.
Great. Thank you for a wonderful session. This question is for Mike you have a significant background in education and simulation. And, at programs like yours and ours, we know that surgical residents are sitting on the consoles for robotic surgery next to us at PGY2 and doing steps of robotic surgery. But again, based on the program, there are many places where the residents or the fellows do not get enough exposure or proficiency in robotics based on the beliefs or the biases of their program directors or fellowship directors. As we look to the future of minimally invasive surgery and the future of education, do you think we need to start thinking about fundamentals of robotic surgery as we move forward, or should we just leave this to institutions and surgeons?
Thanks, Danuja. Great question. I think, whether you think it's the intuitive system or one of the many other emerging systems, I think there's very few of us who don't believe that robotics, or more specifically computer-assisted surgery or procedures, is going to be the way of the future. And just like we believe it's important for our trainees to learn endoscopic procedures, laparoscopic, open, endovascular, to have all of the tools in their toolbox. Similarly, we would be remiss if we didn't include, robotics education with whatever state it's in the current day or year. Towards that having been said, there's in the surgical realms, many of us are familiar with the mandatory curricula in fundamentals of laparoscopic surgery, fundamentals of endoscopic surgery. There has been kind of a concept of fundamentals of robotic surgery and whether that should be a requirement, just as those other curricula are. Today, the access to the technology is still not universally there yet to be able to make that a requirement. And it is so rapidly evolving with new instrumentation, new platforms soon on the horizon. So I don't have a solid answer to that question yet. I do think it's going to be critical as to how we all, not only evaluate the technology, but how we include our trainees in this and get them trained up properly.
We have a question over here.
Oh, thank you. Alana Khan at Mayo Clinic, Arizona. This is a question for Jason. Great talk about AI technology and Barrett's. Just wanted to get your thoughts, the videos that you showed, and I know this is the next step in your sort of algorithm, is putting it in the hands of people who are not as expert in their technique. But I mean, those kinds of examinations are really at an expert level where you've got, Barrett's experts from around the country collecting these videos. And I think we had lectures this morning or earlier this afternoon, I can't remember at this point, which showed, that we are not effectively detecting the patients who need our help. So with that being the background, what kind of work do you see being done either by yourself or other groups in detecting Barrett's, detecting dysplasia in a community setting where maybe you're not going to get the same degree of examination? Are you going to use other techniques like tethered capsule imaging? What are some of the thoughts of how we would deploy that?
I think that's a great question. Thank you so much. I think one of the themes of this meeting has been, at least with Barrett's, is sort of that sort of high quality exam and sort of the critical importance of that. And I think nothing replaces that. And sometimes, we use some of these new advanced imaging technologies and we sort of forget to do the high quality white light exam and high quality MBI exam before we, get the probe down. And I think that's one of the things that I really feel, there's no replacement for that high quality exam. And teaching that has been difficult. We get, great speakers up here talking about, take your time, this is the approach, use the cap. And I think, it just really hasn't penetrated into the community and sort of the general kind of training that fellows get. But I think AI may be able to help with that because we're already seeing this in the colon where some AI algorithms are sort of like speedometers, for withdrawal. So it will detect sort of how many frames they're seeing per second, and if that frame rate is just, too fast, it will actually kind of prompt the endoscopist to slow down, or you've missed this area over here. Why don't you take another look over there? And I think as endoscopists, nobody wants to be policed, So there's sort of this fine balance between sort of coaching and sort of policing the way you're doing endoscopy. But I think that's what we're seeing now in the colon, sort of algorithms that can help the endoscopist sort of change their behavior and how they're actually manipulating the scope and what they're able to do. And I think that is going to be, a great use of AI. So I think Barrett's is no different. I think there's going to be algorithms that are going to be available that can tell you like how well you cleaned the mucosa before you even started the exam. Because I think part of it, some of the lesions I showed, they're so subtle, and as you can see, the cleanliness of that esophagus is perfect. But if you had a little bit of mucus, you would have totally missed it. And so that's sort of one step, the use of the cap, how and what percentage surface area you're seeing, even around the GE junction, sort of taking your time. I think these things can sort of be built in, and we're going to hopefully see acceptance by sort of the greater endoscopic community for these types of tools, because I think, as long as it doesn't take too long and people don't feel like they're really, being policed too much, I think it'll be effective.
Thank you.
So let me follow on with that for a second, because the idea of nobody likes to be policed is there, but we have accepted quality standards in a lot of the different things that we do. We certainly have an adenoma detection rate. We have with minimum average withdrawal time. We've talked about best practices in the Barrett's exam. The nurse, the tech, probably isn't going to try and correct the endoscopist and say you're doing this wrong, or you get your nurses who've been around 30 years, they're glad to tell you when you missed something and you should go back. But for the most part, there are a lot of folks who won't do it. Is this our opportunity to improve quality across the board by utilizing that AI to say, good job, and provide positive feedback, good job, you're doing it right, you're hitting all the quadrants, you're taking the right amount of time, you're at the right speed, and whoa, slow down there, cowboy.
Yeah.
You're going too fast. Is that something that we could use this for in addition to the detection? Is it the overall procedural process that we can use these technologies for?
Mike, I think that's exactly where I see the future. And unfortunately, anybody that's looked at an endoscopy screen sees all this black space on the side of the image, which is sort of just waiting to be filled with sort of metrics and information. And we've thought about, even putting like your posture on there and, all sorts of different things. But I think you're right, that the idea of almost like a live dashboard of how things are going with that endoscopy, I think is a great idea.
Although I would caution that I think when you see some of these technologies, it may be too much information overload, and then it distracts you from the important thing that's in the center of the screen, which is the image of the patient's innards. So
Fair enough.
I see Felice has a question for us.
Really great session, and when I was envisioning it, I thought it would be fabulous like this, and it really was. But I have questions for both Jason and Mike. First for Michael. We talk about ergonomics and how we're probably not doing the right thing, and I agree with you. I've seen so many colleagues who are basically sort of like cripples, especially with ERCP, things like that. I mean, it's shocking how many people have back problems and neck problems and wrist problems and whatnot. Is there anybody looking at stretching during endoscopy somewhere in the section? Like, we would never, I wouldn't go and work out without stretching before and stretching after. And there are people who don't, and those are the ones that hurt themselves all the time because we're lazy with that part. But that seems like such a simple thing to me to do during endoscopy, as opposed to, they're never going to make the scope small enough for my hand. I gave up on that a long time ago, so I learned to do special things to hold the scope in a certain way. But that seems like such an obvious thing from sports medicine that I never see anybody actually talk about. So is there anything that's looked at in terms of that? And then just so I could sit down afterwards, Jason, question for you. has to do, let me think about it. What was my talk question? It'll come back to me. Mike, why don't you, I don't remember what my question was.
Sure, thanks, Felice, and I really appreciate that comment and observation. You know, we are certainly behind in the field of medicine in our attention to ergonomics compared to some of our colleagues outside of the healthcare industry, and actually we have a lot to learn from those folks in industry. You know, there are many strategies to try to address these ergonomic challenges, from, again, working with our industry partners to try to design better tools. You know, ergonomics is the interface between the person and the machine, so to speak, or our environment. And so part of it is what we can do as individuals, and part is what we can do with the environment. As far as individuals, you are alluding to both kind of exercises, stretching, strategies that we can do both kind of during our day and during our procedure. Agree 100% about the importance of both kind of taking appropriate breaks, stretching. Some people do yoga to help kind of ameliorate some of the ergonomic stretches, which has been reported to be very successful. Obviously, also kind of outside of our endoscopy suites or operating rooms, what we can do to maintain exercise and good posture that helps us on those really long and tough cases. But yeah, there's kind of a multi-pronged approach. We're actually on the American College of Surgeons has an ergonomics committee that I sit on, and we're actually kind of putting together some white papers to address some of these issues, including what you just described. So thank you.
And then, Mike, it came to me now what the question was.
Felice, can I just add to the ergonomics question too?
Oh, yeah, please.
So this is actually an area of research interest for me as well. And as you know, but maybe others don't, but there's a wonderful video created by the ASG, Amandeep Shergill, and sort of goes over all of this. And one of the nice things about that video is some sort of practical tips for the endoscopist to do stretching. And so, you know, even as you're taking off your gloves, there's sort of these little sets of, and even when you're putting on your gown, sort of a way to do it to sort of incorporate some of that. We actually had a sort of a quality initiative at our institution where we called it ErgoFest, and it was basically sort of a training for everyone at every level. So all of our staff, all the endoscopists and fellows, the attendings, but also administration, about tools and sort of strategies to help improve ergonomics in the GI lab. And we had a pre-test and a post-test, and we just published that paper. And it was very helpful. And this was a few years ago, and we're still, and I still see things, you know, happening in the GI lab that are thanks to that training. I think you're absolutely right, though. It's a huge problem, and now we're sort of integrating ergonomics training into the fellowship sort of endoscopy training program, and I think that's going to be important as well. But as procedure volumes just get more and more, there's sort of less concern and sort of thought about this issue, and I think it needs to be, you know, sort of brought to light more.
Yeah, I mean, I've never seen someone like, if you're a chef, people have the mats that go under their feet that are soft and, you know, squishy, and certain kinds of shoes, and I've never seen anyone talk about that. Now, I scope in heels, but that's my own problem. Question for you in terms of identification of lesions. One thing I think that we don't talk about is distractions in the room and the lighting in the room. No one ever talks about that, meaning how dark or how light is the optimal way to look at an endoscopic screen. There are times when I walk into the OR to go do cases sometimes, because I do with my other colleagues. I'm like, okay, we need to lower the lights. Or you go into other people's rooms and I'm teaching people, I'm like, okay, the lights need to go up, or the music needs to go off, I think. Or the doors, the two doors that open up on both sides of the way that the endoscopist is facing, bring light in, and people walking in and out and in and out. And, you know, during my time doing a lot of capsule endoscopy, those distractions, we knew they truly affected our detection rate. So it's not exactly AI, but I think it's actually just as important, these other distractions. So do you have any comments on that in the sort of the research that you've been doing leading up to the work that you talked about today?
Great question again. And you know, it's interesting. There was a colleague of mine that did a study looking at colonoscopy and something called the distraction score. And I think when we're doing colonoscopy and we see a semi-dirty colon, we often play the sucking up puddle game. and it's sort of like you get to a puddle, you suck it up, you get to another puddle, you suck that up, and you actually haven't spent any time looking, and so you sort of get distracted by something else, and you're not really using your mental energy on inspection. And I think that's when we train endoscopists, now we think about that. We sort of try to compartmentalize, okay, this is cleaning. I'm just going to spend my mental energy cleaning, and I'm going to stop, and then I'm going to start again, go back to where we started, and just spend all that mental energy on inspection. And with Barrett's, it's the same thing. We sort of try to compartmentalize. It's like, okay, we're just going to clean the esophagus, just get everything beautiful and perfect, and not spend any mental energy on inspection right now. When we're satisfied with how clean the esophagus is, then we're going to start the inspection process. And I think, you're right, that, there's lighting in the room, there's music, there's distraction. I think when you're doing that inspection process or that part of the exam, it's key to have all those things sort of toned down so you can just do the best job possible.
We're almost at the end of our time. In fact, we're probably over, and I see Red shaking his hands, which says we need to move on. So thank you all for a terrific session. Congratulations to our speakers, and we'll move on to the next section now. Dr. Karillis, take it away.
That was a really great session, where we're going in the future, and it's my pleasure now to introduce another great session, which is to introduce the second keynote international speaker on the surgical side this time, and that's Dr. Lars Lundell. Dr. Lundell is an old and dear friend of mine. I'll give you a little background on him. He completed his medical studies and PhD at the University of London, Sweden, where his doctorate was entitled Gastric Mucosal Histamine and Acid Secretion. After basic surgical training, he moved to the University of Gothenburg, Sahlgrenska University Hospital, where he subsequently became chairman of the section of upper GI surgical services. Currently, he is a professor emeritus, Division of Surgery at the Karolinska Institute in Stockholm. He holds numerous clinical research advisorships across Scandinavia. Indicative of this, he has supervised more than 20 PhD theses and was chairman of the UEG Education Committee. He's published more than 350 papers within the fields of acid secretion, peptic ulcer disease, GERD, esophageal-motor disorders, GI malignancies, bariatric surgery, gallstone disease, and the management of paraesophageal hernia. Another very important mission of Lars has been to initiate and develop clinical trial networks within the Scandinavian academic arena, one of the most famous of which you recognize here, the Lotus trial. So without belaboring this further, I'm going to turn this over to Dr. Lundell remotely, where he's going to talk to us about anti-reflux surgery and Barrett's esophagus. Lars, it's a pleasure to have you.
Good afternoon, ladies and gentlemen. First, let me express my sorriness that I couldn't be personally in Nashville to attend this important meeting and reunite with many professional and personal friends. Anyway, it's a great pleasure for me to address the audience, and the topic which has been given to me is outlined above. It is at the same time very relevant to take into account the fact that the first problem we have to realize when it comes to the origin of the name Barrett's esophagus, which is confined to the Australian surgeon Norman Barrett, we have to realize that Norman Barrett got most things quite wrong regarding this condition, not only with respect to the pathogenesis, but in fact, he also denied the existence of the lower esophageal sphincter. And in fact, the rumor says that he was not a very good surgeon either. Now, the dogma teaches us that chronic inflammation induced by reflux at the distal esophagus, and particularly the GE junction, is the engine and the driving force behind the metaplastic and dysplastic lesion transformations leading to Barrett's esophagus and the development of adenocarcinoma of the esophagus. Now, we have to apply a decent perspective on the prevalence and incidence of Barrett's esophagus, because vastly most people who with Barrett's esophagus will not be detected by the medical society throughout their lifetime. And definitely, we also have to realize that the survival in Barrett's cases does not differ from the control population, particularly if we adjust for other known risk factors, such as cardiovascular risk factors. When scrutinizing the surgical literature in Barrett's esophagus, we have to realize some caveats confined to the methodology used. Only exceptionally, for instance, has an endoscopic classification, which is valid as shown here, been used in surgical series. Moreover, a relevant and valid biopsy protocol has also very seldomly been used in surgical series, which is a problem because of the patchy distribution of intestinal metaplasia as well as dysplastic lesions, which of course has a huge implication on the interpretation of the results. Third, we have to realize that the definition of prevalent cancers is not very strict as related to the actual incidence of adenocarcinoma or high-grade dysplasia in Barrett's esophagus when these patients are followed up. If we apply a time limit, for instance, for 1 year from the baseline observation, that the detection of adenocarcinoma high-grade dysplasia is in fact a prevalence of these lesions rather than the incidence. And if we are more strict or more conservative, you could say we'll need to apply a 3-year limit of prevalent of cancers and high-grade dysplasia to be classified as prevalent rather than being classified as incident. And this is important. And fourth, we have also to acknowledge the fact that in the surgical literature, only seldomly have 2 independent specialists, pathologists, been used in the classification and determination of the occurrence of low-grade dysplasia, which is problematic depending on the huge impact of this information, leading to a significant risk for overestimation of the incidence of low-grade dysplasia. Then we also have to realize the fact that in the surgical literature, very seldomly, a risk score has been applied as exemplified here on this slide, that the study population are strictly classified regarding to issues such as cigarette smoking. I talked about the endoscopic classification and also the validity of low-grade dysplasia classification. Now, the issues that I would like to take the opportunity to discuss with you are listed on this slide. And I would like to start with the question of why should reflux surgery in fact be advocated in Barrett's esophagus in general. And the reasons are many. One of those is, of course, that Barrett's esophagus patients are characterized by a huge amount of reflux entering into the esophagus throughout the 24 hours. And moreover, the duodenal component in the reflux differs significantly from Barrett's cases to non-Barrett's reflux cases. And we also know that reflux surgery is more effective and basically can eliminate um, all components in the refluxate, both acid as well as duodenal reflux into the esophagus, which differs from what can be achieved with modern medical therapies, which are, I have to admit, effective in reducing also the duodenal reflux components of the refluxate, but surgery is definitely much more effective, and I will also come back to that a little bit later on. We also know that reflux control is very important when it comes to a complete reflux control, because only short pulses with acid has been shown to induce and maintain cell proliferation in the metaplastic epithelium, which also from this particular perspective would speak in favor of a complete 24-hour control of reflux, which can be achieved by reflux surgery. Another question which has an importance with regard also to the pathogenesis of Barrett's esophagus is, of course, whether we can prevent the de novo development of Barrett's after reflux surgery. And this question is relevant basically irrespective of what kind of ideas and hypotheses we have on the pathogenesis and cells of origin of Barrett's esophagus. Because as Stuart Speckles so elegantly has exemplified by this slide, that the battleground is within the GE junction and the most adjacent portions of the squamous epithelium proximal to the Z line. If we carefully search through the studies which we have in the anti-reflux surgical field, we can say that it is exceedingly seldom that Barrett's esophagus is detected during the follow-up of patients after successful reflux surgery, as shown on this slide. The interesting thing, however, is that if we prospectively follow patients randomized to either PPI or laparoscopic reflux surgery, this very stable situation with regard to the de novo occurrence of Barrett's esophagus is seen also in those patients being allocated to PPI therapy. And in fact, if we follow these patients after a long period of time, you see the same thing after open effective reflux surgery compared to omeprazole, as shown here on this slide, combining both peptic strictures and de novo Barrett's esophagus appearing during the follow-up after randomization and initiation of therapy. There is, however, a caveat here which we need to consider very carefully. If we take biopsies where the biopsy forces is grasping the Z line, i.e. taking tissue from the squamous epithelium as well as this columnar epithelium distal to the Z line, there is a difference in those having an effective and well-functioning reflux procedure, as shown on the left-hand side of the slide, as compared to those being treated with esomeprazole long-term. In that the inflammatory markers are slightly and significantly higher at the Z line in patients having a well-functioning Nissen fundoplication, suggesting that there is a battle going on, or absolutely distal at the Z line, because the fundoplication, if it is correctly done, it is applied absolutely proximal to the Z line, i.e. around the anatomical distal esophagus. This has to be, of course, addressed in future studies with longer follow-up of patients after and reflux surgery. Now, when the question arises whether and reflux surgery is effective in Barrett's esophagus patients and durable as compared to non-Barrett's Barrett's GERD patients, this question arose actually in the late 90s when studies were presented from the United States and from other parts of the world suggesting that the outcome was worse in Barrett's cases compared to non-Barrett's cases, suggesting that you have to apply a different surgical approach in Barrett's as compared to non-Barrett's cases. And in this study from Santiago de Chile suggested that you have to even apply quite mutilating surgical procedures in order to control reflux in these patients. Although most of us do not recognize the problem to being as severe as suggested by this study. Now, during the last decade, there have occurred a number of single institution studies prospectively recording patients with Barrett's and compared to those with non-Barrett's and assess the outcome after and reflux surgery, as shown here from Adelaide, for instance, showing basically the same outcome in Barrett's as compared to non-Barrett's cases, symptomatology-wise. And if you scrutinize the literature, which is quite extensive, although all series have a quite limited number of patients and there are very few well-powered, basically no single well-powered and randomized control clinical trial within the field. But at the end of the day, I think it is reasonable to conclude that the success rate from a clinical perspective of reflux surgery in Barrett's esophagus centers around a 5-year success rate in the range of 85 to 90%. And this is a figure which is very similar to what we see in non-Barrett's cases. In the randomized clinical trials, which did not use an updated medical therapy, there was an advantage of reflux surgery as compared to medical therapy, whereas in the Lotus trial, where we had a quite significant number of Barrett's cases, we were not able to detect a difference in terms of reflux control with 24-hour pH monitoring between non-Barrett's and Barrett's cases, although there was a difference if you compare the level of reflux control with the medical therapies. But in terms of clinical outcome, there was no difference between Barrett's and non-Barrett's cases. So I think it is reasonable to say Barrett's esophagus cases are doing as well as non-Barrett's cases after surgery. Now, can reflux surgery prevent dysplastic and neoplastic changes from occurring? The indication should, of course, not be used and as such that this could be a cancer-preventing operation. But there is a logic and there is a reasonable hypothesis to say that if we can control any kind of reflux effectively at the GE junction and the distal esophagus, it is reasonable to believe that we can also control chronic inflammation and thereby the proliferative drive to the metaplastic epithelium. A pivotal study when it comes to the control of inflammation and the additional value of controlling reflux is the so-called ASPECT study, comparing the value of aspirin plus low or high dose PPI in long segment Barrett's esophagus cases. The outcome is very clear. There are two important pieces of information here when it comes to the cumulative survival the high dose is more effective than low dose of PPI, suggesting that the level of reflux control is important. Second, the additional value of acid reflux control is significant to the effect of aspirin. And therefore, you can say, well, this is a very strong evidence that reflux control as such is an important factor to control this process of proliferative drive on the mucosa of the distal esophagus and GE junction. However, data have been suggested that an anti-inflammatory effect as such is residing within the modern PPIs. And this additional effect of high dose PPI to aspirin would suggest that there is an additional effect that can not be confined to the potential anti-inflammatory effect of the PPI as such. Moreover, in the LOTUS trial, we studied the inflammatory responses in the stomach concomitant with the inflammatory responses in the esophagus. And as shown here, there is no effect over time by esomeprazole on inflammatory parameters in the stomach, suggesting that the anti-inflammatory, potentially anti-inflammatory effects of esomeprazole and PPIs is not an important factor in this particular arena. Now, the literature suggests, taking into account the many methodological shortcomings of the surgical literature, the meta-analysis would suggest that there is a protective effect of anti-reflux surgery on the development of adenocarcinoma in patients with Barrett's esophagus. The caveats are many. One of those is that this effect, this possible effect on the regression of, for instance, on the regression of Barrett's esophagus is confined, can only be seen in patients where you have an adequate and complete reflux control, as shown here, for instance, by the Bravo capsule. And the prognostic factor is, of course, the level of reflux control. On a population base, it is basically impossible today to argue that anti-reflux surgery has a better effect on the development of high-grade dysplasia and adenocarcinoma as compared to those Barrett's cases being treated with medical therapies. And this is shown, for instance, here in a big UK study and in a Nordic study containing hundreds of thousands of patients. You see here that the risk of adenocarcinoma development is basically stable over more than 15 years, which you could say can be interpreted as an argument of a protective effect, because otherwise the risk would increase over time. Even in patients with severe GERD, including a lot of Barrett's esophagus, but it's difficult from a definition and classification point of view to say so. Now, if you compare this to the so-called, quote, background population, unquote, you have no difference, the same stable situation. The problem is, however, that only these patients have been treated in the Nordic countries with PPIs, showing the same risk development or stable risk over time in PPI-treated background population as compared to those having an anti-reflux operation. So I think we cannot conclude that if there is a protective effect of anti-reflux surgery, it is different from that obtained by modern PPI therapy. Last, a look into the crystal ball. Well, there is a problem with anti-reflux surgery because it is severely underused in many countries, wherever it has been studied, and this is definitely so in the Nordic countries. This is unfortunate because we know that when it's done in high volume centers by experts, it's very effective, even if we follow these patients more than 50 years. And I think that this US veteran study by Spechler and his colleagues is offers a very strong argument that in very well-defined so-called refractory heartburn cases, and reflux surgery is absolutely superior and should be a game changer when it comes to the indication for end reflux surgery in these particular patients. Now, when it comes to the effect of radiofrequency ablation, we know that control of reflux is extremely important when we're talking about the risk of recurrence. And this is an established indication today in most parts of the world, but the problem of recurrence is still of clinical significance. And therefore, we also have to realize that the adjustment of the anti-secretory therapy is vital for the success rate and the slope of the recurrence-free survival in these particular patients. And having said this, there is a window of opportunity for end reflux surgery to be used in this particular situation, although it is difficult based on the current literature to show that the pretreatment with a fundoplication would be of value as such to prevent recurrence. But there are circumstantial evidence from other types of studies with long-term follow-up suggesting that the combination of local eradication therapy with end reflux surgery is a very attractive therapy and needs to be studied in prospective studies in the future in order to address the problem and give guidance to the clinician. Human experimental situation where it is allowed to see barriers developing under the eyes of the endoscopist is this proximal esophagus after esophagectomy, as shown here, both in patients operated on for Barrett's cancer as well as for squamous cell carcinoma. And this is a human experimental situation which needs to be used, and definitely so, and I'm sorry to say, also after sleeve gastrectomy, where the annual incidence of Barrett's esophagus is in the range of 3 to 4%. And this is, of course, something which needs to be studied very carefully. So having said this, after a brief look into the crystal ball, these are a couple of issues that I can see in the crystal ball. And definitely the show will go on. Thank you very much indeed.
Thank you so much, Lars. It was good to see you and hear you, if not have a drink with you. See, he can't hear me, obviously. So Lars is going to get one of the International Speakers Awards from us today, and rather than call him back in the middle of the Nordic night, we're going to present that to him now. So Reg Bell is going to give that presentation.
Well, Lars, I don't know if you can hear us at all. I've followed Dr. Lundell's work, Professor Lundell's work for years. In fact, he was probably the one...
The sound is too low.
You're there? Okay. The sound is too low. So, well, good to see your face there, Professor Lundell. So,
hello.
Professor Lundell is probably one of the most unbiased surgeons that I have ever met. When he has looked at research, he has looked at it from a scientific point of view. He has always presented his data in an unbiased fashion. And for that, we really have to thank him. So it's really with honor that I present to you our 2021 International Clinician Award, and thank you immensely for your years of service and research and thoughtfulness about Barrett's esophagus, anti-reflux surgery, along with the multiple other studies that you've conducted. So thank you very much. We're honored to have you and have heard from you today.
Thank you very much indeed. Can you, Greg, allow me to say a few words?
Yes.
Of course, I'm immensely glad and proud to receive this most prestigious AFS International Clinician Award. And as you may know, this feeling of mine is based above all on the fact that the AFS contains the vision, the mission, as well as the structure and roadmap for successful clinical research in the field of gastroenterology, which means that the society fosters and endorses interdisciplinary collaboration and communication, which I think is absolutely vital. And as you know, the core theme of my own clinical research career has in fact been to address, critically evaluate and develop management strategies of upper GI diseases. And the key to success has been to seek collaboration over the traditional boundaries between specialties. And this approach has been based on mutual respect and understanding. And therefore, I think that this award means not only extremely much to me and represents a milestone in my own life, but it gives also a very clear message to the medical society how to proceed in the present and the future clinical research arena. And having said this, I would like to say to you wholeheartedly, thank you very much. And I direct this to the society as such and to the award committee.
You are more than welcome.
Thank you.
Delighted to have, to be able to share that from Dr. Lundell. So it's 2:40 now. Let's give it a 15-minute break. I can't read that. 20-minute break. 3 o'clock. Let's reconvene at 3 o'clock, and we'll finish off the day. For those of you who may be thinking about next year already, it's a week earlier, October 15th through 17th in Orlando, Gaylord. So put that on your calendars as you're walking out the door. Put that on your calendars now. September, not October. I'm already moving ahead.